Hello. Yeah.
One, two. Yeah. You can hear me all right?
Hello. Hello. Hello.
Good evening, friends. It's with great pleasure and pride that I welcome you back to our PG Clinics broadcast. We were away for some time because of logistic reasons, and we hope to be back for some time to come without any interruptions. For today's broadcast, we must express our gratitude to Blue Cross Laboratories, who have given us a generous grant so that we can continue this activity. And of course, I must express gratitude to Dr. Raju Khubchandani, who was instrumental on getting them on board for this episode. For today's episode, our focus will be on pediatric rheumatology, and we have two eminent experts, one from our country and one from UK, who are going to guide us through this session. Our guest from UK is Dr. Helen Foster. She is a pediatric rheumatologist, and I will not say much about her right now. You will see when she starts talking rheumatology what it is all about. And of course, we all know Dr. Raju Khubchandani, who is a pioneer in pediatric rheumatology in India. Without wasting more time, I think we should get on with the clinic. Dr. Anita, come.
Good evening, everybody. My patient, Fenwick, 12 years old male child, second by birth order, born of non-consanguineous marriage, Hindu by religion, Gujarati by community, residing at Nalasopara and hailing from Gujarat, brought by and informed by parents with chief complaint of swelling of the joints since 2 years of age. Patient was apparently alright till 2 years of age when father noticed swelling of bilateral knees to begin with, and simultaneously involving swelling of the fingers, which was insidious in onset, progressive in nature, associated with redness of the knees and fingers. Simultaneously, the swelling also progressed to involve the elbow and the wrist. There was associated joint pains, which was severe, affecting daily activities in the form that the child was not able to walk or not even able to get up from the supine position.
Could we stop here for a minute?
Yes.
So just very slowly repeat what you have said so far.
12 years old male child with chief complaint of swelling of the joints since 2 years of age.
Right. So let me ask you a question. Let me ask you a question, and that is that what are the types of diseases that you might think which may create swelling of the joints at 2 years of age?
It could be a trauma. Trauma could cause swelling of the joints. Then hemophilia causing joint swelling. Even vitamin C deficiency could cause joint swelling.
Right. Now, what sort of joint swelling would you see in trauma?
In trauma, there is sudden onset and there is history of preceding trauma, which will be severely severe with associated severe pain, and mostly involving either unilateral limb or whichever joint. It's not symmetrical.
So would you see a single joint or would you see multiple
single
joints?
joint involvement in trauma.
Usually single. Suppose you saw multi-joint or multi-focus involvement in a setting of trauma. What would you suspect? A 2-year-old child, would anybody? Yeah. What would you suspect? Yes, anybody from the audience?
Battered baby.
So, what is the more technically correct name for battered?
Child abuse.
Even more technically correct? Anybody from here? So, has anyone heard the term non-accidental injury? Yeah? So, that would be one possibility. Okay. Would you suspect septic arthritis? Anybody from the audience, would you suspect septic arthritis? We are not saying that he's 12 years old and therefore for 10 years he's had septic arthritis. But onset at 2 years of age, would you suspect septic arthritis? If it's single joint versus multiple joints. Yes? Anybody?
Mostly single septic arthritis would be a hip involvement, single joint, and that are progressing to other joints.
Would perhaps be a single joint.
Yes.
Right. Do you have multiple joint involvement in septic arthritis?
Yes.
Very, very uncommon, except perhaps in a neonate who's septic, but otherwise by and large no. What about hemophilia? She used the word hemophilia. What's the type of joint involvement in hemophilia? And in a 2-year-old, would you suspect hemophilia if the child has multiple joints involved? So what's the pattern of joint involvement in hemophilia? Yes?
Large joints and single joints to be involved.
Anything more you would like to say about joint involvement
on the
in
pressure?
Yeah, so typically you see this in a slightly older child the moment he starts to weight bear. The moment he's 3 or 4 and starts walking and starts weight bearing, and then it would be in the lower limb joints. Yeah, so the point I'm trying to make is very early in our presentation. The point I'm trying to make is that rheumatology, a diagnosis is all about pattern recognition. Right? Which we will talk about as time goes by. But the pattern she has spoken about is multiple joints involved so far. That's the information we've got. And a very long history. These are the 2 points that we need to keep in mind so far. Right? Helen, would you like to add something here?
Yes, I think obviously I completely agree with what you've said so far, but at the age of 2, I'd want to know had he had any illnesses beforehand, suggest maybe a reactive arthritis, or like you see rheumatic fever here, but you think about infection or a reactive arthritis perhaps, that maybe history may include a fever or a rash or a gastroenteritis type presentation.
There was a history of fever prior to the episode, but there was no history of rash or any acute gastroenteritis. I'll go further. On inquiry, there was history of fever for 15 days prior to this swelling, which was high grade, intermittent, and was not associated with any rash over the body, which was intermittent kind and used to reduce with waxing and waning course of the fever.
So, I know that it's very difficult to recall the pattern of fever, how it was 10 years ago. But suppose I told you that this child's fever was this was a hypothetical child who says that he gets 1 or 2 spikes in a day. And when he gets that spike, it's 104. And he's so sick, he curls up in bed, he shivers, he gets chills. And then, the moment the fever goes away, he's absolutely happy in the interfebrile period. Right? What is this pattern of fever called?
Quotidian type of
It's
fever.
a quotidian type of fever. That's extremely well said. And suppose he had told you that he also had a rash. What more would you have asked him about this rash? Anyone? Look, this question is not only for her. It's for anybody here. It's anybody who's watching us on the webcast. What's the pattern of rash that you would ask for? An evanescent rash. So what is an evanescent rash?
Rash appears only during the febrile period and it disappears after the fever.
After the fever disappears. And therefore,
Hold the mic because it's going all across. So talk in the mic, please.
An evanescent rash is a rash that appears once when the fever, with the onset of fever, and disappears once the fever disappears. So
Right.
that's in an acute rheumatic.
and do you know often what happens in the ward when this evanescent rash comes? Usually the chief has started some new antibiotic and gone away because it's 20 days of fever, so you're experimenting with antibiotics. And these rashes invariably get labeled as drug rashes, and therefore, rather than recognize the rash, the drug is changed over. You know? And the rash comes once and goes away, very well seen on a fair skin, salmon pink, and usually on the trunk and the proximal parts of the extremities. Yeah? So that would be the rash. But you say this child didn't have a rash, but he did have fever for 15 days before the joint swelling began. Okay? Right?
There was no history of any other illness associated with fever, like any gastroenteritis. And these complaints of swelling and was associated with pain, which reduced the activity of the child, such that the child was not able to walk or even get up from supine position because of the pain in the pain. And the parents also said that the child had these symptoms mostly in the morning with relieving of the.
I think we should stop there. That is a very, very crucial statement that she made. The pain was mostly in the morning. Right? So, why was she so very emphatic about this morning statement? She could have well skipped it. Could anybody answer me? Anyone? Here, she obviously knows the answer, so we'll ask her last. What about anybody in the audience? Okay, tell us. Why is it relevant to ask for morning pain?
Because multiple symmetrical joint involvement going towards the rheumatic etiology, which are they have the following a long period of inactivity, there is gelling of these joints causing morning stiffness, which gradually reduces over a period of during the day.
So suppose he told you that the pain was in the evening and not in the morning, then what would you have concluded?
Whether there was a period of activity or whether there was a period of inactivity during the day could have been the issue if the child had to.
So does this, let me ask you in a more direct fashion, does a morning pain versus an evening pain give you a clue to etiology?
In the morning pain could be suggestive of rheumatic etiology, while evening pains in a child of 2 to 3 years.
What do you mean by rheumatic etiology? You need to be a little more specific.
Juvenile could be suggestive of juvenile.
No, I think what it means is, Helen, would you like to specify it to them?
Inflammatory joint pain is typically worse in the mornings after a period of inactivity and rest overnight, and mechanical type pain is worse often later in the day after periods of activity. But the inflammatory joint pain may also occur after periods of activity during the day, so a child sitting on the floor, maybe at school, or sitting in the car for a period of time. When they try to move again, their joints may feel sore and they may feel quite stiff, and we call that gelling. So gelling is equivalent to morning stiffness and inflammatory joint pain that we often see.
So what Helen tried to say was that it's not only morning pain, it's morning or, for example, any other period of inactivity. So if you have, in India, so many children have an afternoon nap, and then when they get up at 4:30 or 5 in the evening, they're back into their limping mode again. Yeah? So this is very important to differentiate inflammatory pain from non-inflammatory pain. Now,
Raju, what happens if the pain is all the time? You said morning or evening.
right.
There could be pain on rest, there could be pain on activity. What
Right.
would that mean?
It could be an infective.
So, if you have something like a septic arthritis, then that's not going to see time boundaries. That's a severe infection which is going to see pain all the time. But, by and large, if you have a pain which is all the time and especially more at night, then I'm a very worried man, because it often signifies malignancy, which you have to be very, very careful about. Nocturnal pains, and these are usually, like Dr. Amdekar said, generalized pains, which even the child resists being touched. The moment the mother goes to try and even pick him up to comfort him, he's rather left alone by himself rather than be touched or picked up. He wants to be just lying on his own. But remember that another important cause of nocturnal pains which are localized are osteoid osteomas. They are benign tumors, but they cause significant, for unknown reasons, nocturnal pain. Yeah? So this is the importance. Yes?
Why are the inflammatory pains worse in the morning?
Why are they worse?
Why are they worse?
So there are several reasons believed. One of the theories is that whatever are the chemicals which are responsible for the causation of pain get pooled over there by virtue of the inactivity. And the moment the activity starts and the muscle movements begin, those chemicals get washed away from there, and therefore it helps the pain relief. While the mechanical pains like hypermobility, etc., would invariably come after those muscles are tired and exercised.
And gradually, for these above complaints, patient was shown to the family physician, where he was given medications which used to relieve the symptoms of pain temporarily, but which to recur again after a period of few days. And gradually, over a period of time, the child developed deformities in the form.
So suppose you were the family physician, right? What are the possible medicines you may have written for this child?
Analgesics for the pain.
Okay, so this brings me to an important question. Which are the analgesics which are reasonably permitted for pediatric usage?
Paracetamol.
Okay, but paracetamol is an analgesic but not an anti-inflammatory, right? So one will, okay, we will buy paracetamol. What else?
Ibuprofen.
Ibuprofen, yes.
Naproxen.
Naproxen. And perhaps these would be the real common ones. Aspirin finds very localized applications. Can somebody tell me today, in which disease today do we use aspirin the maximum? Kawasaki disease. Absolutely. And in what doses do we use it for Kawasaki disease? Sorry?
100.
Yeah, go ahead. Yeah. Mic, please use the mic. Yeah, go ahead.
mg 70 to 100 mg per kg per day in initially 3 to 4 days, then followed by 5 to 7 mg per kg per day in the maintenance phase in Kawasaki disease.
So, what does the 70 to 100 mg per kg do, and what does the 3 to 5 do?
Anti-inflammatory.
70 to 100 is the anti-inflammatory dose, and then the 3 to 5 is to prevent the complication of thrombosis.
So that's called the anti-platelet dose, right? So you have the anti-inflammatory dose and the anti-platelet dose. Anyway, that was a digression. So we spoke about the two anti-inflammatories which are licensed for use in children and available in India, naproxen and
Ibuprofen.
ibuprofen. Yeah, okay.
Gradually, over a period of time, child developed.
Would you have used steroids?
No.
Why not?
Before the diagnosis of the patient, it's not wise to use steroids.
But this patient is very insistent. Doc, my child is running with pain. You better do something fast. Would you use steroids?
No.
After the diagnosis, would you use steroids?
Yes, sir.
You would. And what are you worried about not using steroids?
Not using steroids.
Why would you, before a diagnosis, you are very categoric that you don't wish to use steroids. Would anybody tell me why she's scared of using steroids before a diagnosis? But this is a polyarticular disease, right? So we are not very worried about a septic arthritis. Is there anything else you are worried about?
Malignancies.
Malignancy. Which malignancy are you mostly worried about?
Leukemias or...
Leukemias.
The initial corticosteroids could suppress the...
could mask the entire picture and confuse you for the next few months. Alright? And the typical scenario would be a hemoglobin of 9, a white cell count which looks deceptively normal at 5,000, but the lymphocytes are 72, the polymorphs are 24, and the platelets are at 150,000. So you know that there is something brewing over here. The lymphocytes are too high. This child has polyarticular joint pain. Looks like a sick kid. Right? There's no way you're going to touch steroids in this patient. Right? Okay.
Gradually, over a period of time, a child developed deformities in the form of flexion deformities of the fingers and the elbow and knee, to such an extent that child was not able to walk upstairs and downstairs, and was not able to sit cross-legged, and was unable to even dress his clothes in the form of buttoning or unbuttoning his shirts.
Okay. So, see, you told me a little more about the pattern of the fever, right? But you didn't tell me too much about the pattern of the joint involvement, right? So have you told me whether large joints were involved or small joints were involved?
Large joints were involved. First to be the knees were involved, and then followed by the elbow, wrist, and the fingers. Small joints like the fingers were involved.
So why are we going so crazy about finding out whether it's large joints or small joints or large and small joints or either of the two? Anyone? Would you tell us? So there are certain diseases in rheumatology which would involve only large joints, by and large, right? There's no fixed rule, there are exceptions, but a disease like, for example, rheumatic fever involves large joints. But the moment you have small joint involvement, you will start thinking of other connective tissue disorders, right? And there are certain specific small joints which may straight give you a diagnosis. For example, you have the distal interphalangeal joint involved, and what's the disease? Absolutely fantastic.
Sir, a couple of questions here, Anand.
Yeah, yes, Anand.
So, first is, I don't think the people online got the answer about Kawasaki and aspirin. How long is that 70 to 100 milligram per kg dose to be given? That's the first question. And there is another question, is whether this can be considered as growing pains initially. And could you tell us about these growing pains? What exactly are these?
So I'll answer the Kawasaki part and let Helen speak about the growing pains part. Yeah. So the Kawasaki answer is that you would give the anti-inflammatory dose till the child is afebrile. And then you will start the antiplatelet dose and go on with the antiplatelet dose for at least 6 weeks. Around 6 weeks you would be repeating a platelet count to ensure that the platelet count is within normal limits, which is also the time that you would do the two-dimensional echo again and then pronounce the child as absolutely certified normal, as by today's method of evaluating the coronaries. There is a certain restriction that today's 2D echo has. Maybe 10 years down the line, we'll have a better method of imaging the coronaries, at which time we may say that, oh God, we've stopped aspirin too prematurely. But as of today, that's what we would do. On the other hand, if the 2D echo still shows anomaly, then we would continue aspirin till those anomalies disappear. As far as growing pains, Helen?
Okay, thank you. That's a very good question. And sometimes children are labelled with growing pains when the diagnosis is not clear. It's very important to know what the rules of growing pains are so that you can be quite sure when to say, I'm not happy and this child needs further investigation. And this child clearly does not have growing pains for several reasons. The most important one from my point of view is that he has daytime symptoms and he has functional limitation and he's clearly not well. Growing pains typically are aches and pains, often in the lower limbs. This child has problems in their upper limbs, their fingers and elbows, we've already heard about. The child clearly has abnormalities on examination, which you would not have with growing pains. The child has clearly got symptoms of functional limitation. We've heard about problems at school, problems with dressing, problems with going up and down stairs and getting up off the floor. So functional limitation, the child has not got growing pains. If the child is limping, then they haven't got growing pains either. So the rules of growing pains are symmetrical aches and pains, usually lower limbs, end of the day, quite mechanical type pains, which different to what we've heard about. They're not in the mornings. The child can be fine in the day, but go to bed and wake up at night time with severe pain, often crampy type pains in the legs. But there's nothing to find when the child is examined. So the localized pains, maybe in the muscles, maybe the joints, the calves. They're often quite non-specific, but they have to involve both sides. So the child that has always a pain on the right side or the left side has not got growing pains. This child was 2 at presentation, so it's rather young, I would say, to have growing pains anyway. So the rules that I learnt many years ago were the ages of between 4 and 12. You would agree, Raju, but a very young child, under the age of 4, I would be very worried about saying this is growing pains. And if the child is examined, completely normal examination, a well child, and normal blood tests, but often we can diagnose growing pains without any blood tests at all. You don't have to do blood tests to confirm a diagnosis. It's a clinical diagnosis in a discrete scenario, and if you obey the rules of growing pains, you won't go far wrong.
Thank you. Sir, one more common response of most pediatricians to this kind of a story is label it as JRA and forget about it. Is that correct? Would we be right in the early stages of the disease? That's a reflex most people have.
No, so here is the story that first of all, I'm going back in time to when this patient first came and said that he has 15 days of fever and he has multiple joints involved in an inflammatory fashion. Now let's understand that as far as the diagnosis of JIA is concerned, remember that it's not that anything you don't recognize is JIA, right? It may be idiopathic to you, but it may not be idiopathic to somebody else. We are talking about a setting where it's idiopathic to everyone before you label it as JIA. So while JIA is a diagnosis of exclusion, there are certain criteria for each of the subdivisions of JIA which have to be obeyed. And amongst those, first is that the child is below 16 years of age. And this, I must say, is arbitrary. It's not that at 16 some switch goes on or off which makes you an adult suddenly. The second is that there is no other cause identifiable. And the third part is that the disease has been going on for 6 weeks. Now you'll say, why 6 weeks? What's so sacrosanct again about 6 weeks? It's by and large because most of the background noise, and when I say background noise, what I mean is the children with reactive arthritis. You heard Helen talking about I'd like to know whether there's fever, there was rash, there was something else happening. Because any of these post-viral arthritides or the reactive arthritides usually run their course within about 4 to 6 weeks. So that's the background noise we are referring to, and those are out of the way. And that there is a clear pattern which you are recognizing by now. And once that clear pattern is recognized, you slot him into JIA, families JIA, subfamily X, Y, Z, or whatever the 6 or 7 types there are.
So, just to understand this more clearly, for that 6-week period when the child is suffering from pain, it's okay to give him anti-inflammatory analgesic medications.
Absolutely.
So he does get relief, because many people have this concept that you can't give them drugs, it will modify the course of the disease, and that's why the child has to suffer.
Don't give him steroids.
Yeah, that was very clear.
Use anti-inflammatories, make him comfortable, and keep watching for ancillary features. And remember one thing, that except for systemic onset JI, in all the other JIs, right, there is no or little extra articular involvement. So it's joints and joints alone. Systemic onset JI, you'll have rashes, you'll have serositis, you'll have adenopathy, you'll have fever, you'll have all these things. Organomegaly. But in the other GI varieties, if somebody told me he's got oligo GI and he's got 103 fever every day, I'll say no. Please look for something else. You know, he's got enthesitis related arthritis and he's got 102 fever and he's got adenopathy and he's got mouth ulcers. Then I'll say please look for inflammatory bowel disease in this child. Okay? So, a marked paucity of extra articular features except in systemic onset GI.
For these 6 weeks, do we call it reactive arthritis or we call it evolving arthritis, or is there a difference? Or
I prefer to be honest and tell the patient I do.
Thank you, sir.
At present, now the child can do his own routine activities and can play his simple...
Sorry. So, you've told me that this child has an inflammatory pain. You've told me that this child's inflammatory pain was preceded by a reasonably symmetric fever. You've told me that it was large and small joints that were involved. Right? Now, there's another thing you haven't told me, and that is, what was the nature of onset? Was it fleeting? Was it additive?
It was not fleeting. The joint involvement was symmetrical and it was additive to the previous existing joints. First the knee joint was involved and then followed by the elbow and the fingers. And initially for the first, the father noticed simultaneous involvement of the knees and the fingers, and then followed by elbows, the wrist.
So in which disease do you get fleeting arthritis? Anybody?
Acute
rheumatic fever, you get a fleeting large joint arthritis. So one joint is inflamed, that settles down, and in fact the rule is that if a given joint is involved for more than 7 days, chances are you're not dealing with rheumatic fever. Okay? So that's another important point to keep in mind. And there's one more thing you haven't told me yet about the joints, and this is why I'm talking about pattern recognition. What is the other important point? Peripheral joints versus axial joints. Correct?
Yes.
So what information does that tell me? Peripheral joints versus axial joints. Somebody? Anybody? Okay. So, you've heard of the somebody said spondyloarthropathies, correct? But suppose I had a 2-year-old child, like he was, and he had a backache. Would you have thought of spondyloarthropathy in that age group?
Ankylosing spondylitis.
In a 2-year-old with high fever? You know what would be highest on my mind?
Malignancy.
But he also has peripheral joint arthritis, right? Leukemia would be highest on my mind. Alright? Leukemia would be highest on my mind. Yeah? So backache, the smaller the child, the more sinister is a backache. Remember that. A backache should be like a red flag in your mind. That the moment there's backache, there's trouble. Yeah?
There was no history of pain in the neck or any restriction of neck movements or no history of pain in the back. There's no history of trauma, no history of any fleeting joint pains.
Suppose this mother told you that he has difficulty feeding, he doesn't open his mouth. Suppose you saw a 14-year-old boy, no, not 14, let's say a 16-year-old boy who comes to you with a unilateral arthritis of the sternoclavicular joint. And it's red, hot and swollen. What would you look for? What is likely to be this patient's habit? Sorry?
Gonococcal.
Gonococcal, no. Basically, this is peculiarly a unique type of arthritis seen in heroin addicts. Patients who are injecting themselves IV. They get septic arthritis of the sternoclavicular joint. Okay? So, the point, again, I'm trying to make is that rheumatology is all about recognizing a pattern. Right? You've said, is it inflammatory or is it non-inflammatory? Is it large joint or is it small joint? Is it fleeting or is it additive or is it intermittent? It comes for 7 days and then it goes away. Right? So let's pause. Intermittent arthritis in a child living near Nagpur in the Adivasi area. What is that? Yeah, I think I gave too many clues over here. I should have just said living near Nagpur. Okay? And then asked you. So sickle is the answer there. Okay. And then is it peripheral or is it axial? Are there extraarticular features? Are there no extraarticular features? Right? So this is how you've constructed the whole story. Right? So I think this gives us a reasonable idea, but let's move to something much more exciting, which is, you know, you're going to witness somebody who's known the world over for this, and we'll move to how we will examine this child, right? Because this child, I must say, has had an old disease, and today this child is here because there are certain signs that we wish to document and demonstrate, which Helen will be doing. And is there a child who's normal?
Yes.
Yeah?
Yes, sir.
So Helen, let me ask you, what is PGALS?
PGALS stands for Pediatric Gait, Arms, Legs and Spine, and it's a very simple set of maneuvers that enable you to examine a child really from head to toe to identify whether a joint is normal or abnormal. Right.
But why did you have to go spending time doing PGALS? You could very well have used the adult GALS system. Why did you specially devise something separate for children?
We tried the adult GALS first. Adult GALS I learnt at medical school a long time ago, and the adult GALS is a comprehensive examination system for adults, but it missed problems in children at the foot and ankle, and it missed problems at the temporomandibular joint, and it missed some of the wrist involvement, because the original adult GALS didn't include some of the manoeuvres that we then added in to cover those joints. So foot and ankle is a very, very important set of joints to examine in children. It's a commonly affected joint at the presentation of juvenile idiopathic arthritis. So it's very important to make sure that wasn't missed. And the TMJ, as you've heard, is a commonly affected joint, so we added a manoeuvre in for that. And we added additional manoeuvres for the wrist to try and improve the sensitivity.
So subsequently, have the adults learned some lessons from us and tried to adapt these also into their system, or are they refractory to learn?
No, I think it's very good to hear that they've, for a change, adult practices learnt from paediatrics. It's usually the other way around. But the newer version of GALS also includes the TMJ assessment, and I think medical students now, if they do the paediatric version of GALS on an adult, that's fine by me, and they often do the wrist manoeuvres that we developed from PGALS.
Now let me tell you one thing, Helen, very clear up front. An average pediatrician sees about 100 kids in a day. A busy semi-urban pediatrician, rural pediatrician sees 100 kids in a day. And if you're going to tell me that even if it takes just 2 minutes to do, that's 200 minutes, that's 3.5 hours of your day gone in just examining that. So suppose I tell you, which are the patients in whom you would say it's mandatory to do a PGALS?
Okay, I mean, one could argue that you would never not examine a child's heart, whatever the presentation, and one could argue that you should always examine a child's joints. But I take your point that in a busy real-life practice, you often do take shortcuts. But I think it's really important that there are various clinical scenarios where a musculoskeletal examination is mandatory. Certainly a child with a fever, and the presentation we've heard about would certainly fit with that. So a child with a fever, a child with limb or bone pain or back pain, absolutely. A child with a limp, a child with regression of maybe their achieved milestone. So a child that maybe has been keen to walk but no longer is keen to walk. Even if there's no obvious localization where the pain, if they have pain at all, where the pain might be, it's very important to do a joint examination, because you may pick up on joint involvement that wasn't apparent from the history. And then the final one would be in children with chronic illnesses like maybe inflammatory bowel disease, who may come along with pain, and they have a clear association with inflammatory joint disease as part of their chronic illness. So they will be my key presentations.
And perhaps if I might add one more, any child with multi-system disease, because very often multi-system diseases turn out to have a rheumatologic basis for their occurrence. So in these you would say a PGALS is non-negotiable. Ideally you would say in everybody, but otherwise a PGALS is non-negotiable. Now tell me, you have spoken about the PGALS. Is the PGALS a well-validated score?
We tried very hard to validate PGALS, and we took a sample of children in our clinic between the ages of 4 and above, so school-age children, and then we looked at a consecutive series of children, and we had them assessed by a paediatric rheumatologist, then also by another, it was actually a trainee who'd been in our clinic, who was blind to the history, who assessed the child first, and the same day the same child was examined by a paediatric rheumatologist. We recorded our results independently, and then we compared notes, and we found that actually the assessment by the trainee without the history and the assessment by the consultant was very, very similar in identifying which joints were affected and which joints were affected in each child. And so we found that the different manoeuvres were very sensitive in picking up a joint abnormality. So sensitivity was 97% and above in most joints, picking up, is this joint abnormal or normal?
What about specificity?
Specificity, it's important to realise that PGALS is not diagnostic. It doesn't diagnose JIA or septic arthritis or anything else for that matter. You must interpret the findings with the clinical context. So your history and the rest of the clinical presentation is really important. So children with a cerebral palsy, for example, will have an abnormal PGALS. A child with a septic arthritis will have abnormal P-gals, as may a child with juvenile idiopathic arthritis. So you have to interpret what you find by what you've heard from the story, by the blood test that you may have at your disposal, and imaging. But it's very much, it tells you, is the joint abnormal or normal, and you can then focus your more detailed examination or further examination thereafter.
Is there an age bracket in which you do P-gals for which it's valid? Can you do it, say, in a 2-year-old or a 1.5-year-old?
The validation exercise was in 4 years and above. So it was validated in school-age children. But there's no doubt that younger children can do the P-gals manoeuvres. In a 2-year-old, like in the presentation that we've heard about this evening, a child cannot do active movements, but they can certainly do passive movements, and you can do them with the child in the sequence of P-gals. But a toddler, so a child who's 3 or 4, they can copy you game, if you like. So even though it's not validated in that age group, if you go through the sequence of manoeuvres.
I had a deaf-mute child with arthritis, and all that she did was she followed my maneuvers that I was showing her with the hand, and she was doing it herself. Have you had any experience like this?
Yes, we've had children who either have either English is not their first language, so there's a language barrier, or children who may be deaf, for example. We've had the same thing, and they can really nicely do a copy me exercise. And one of my trainees used P-gals when she was working in Malawi, and obviously language was a major barrier at that time, and so the copy me exercise worked beautifully for the child to copy her and then to pick up abnormalities on the P-gal screen.
Right. So I think without much ado, Helen, would you please give a demo of how you would do the P-gals and explain. I think what we'll do is we'll first take a normal child, and then we have 2 children who might show us some signs. So you could first demonstrate the entire exercise on the normal child, and then Fenwick would volunteer for the other signs, residual signs that he has.
Okay. Hello? So P-gals would normally start with 3 questions. So, hello, nice to meet you. Thank you for coming. So P-gals would normally start with 3 questions. So we could either ask you or ask a parent who might be with you, do you have any pain anywhere? No? That's good to hear. So we ask about pain in joints, muscles, or in the back. Do you have any problems going up and down stairs? Do you have stairs in your house? Any problems going up and down stairs?
सीढ़ी चढ़ते वक्त या उतरते वक्त तकलीफ होती है बेटा?
No, so we have no problem on stairs. Any problem getting dressed or undressed?
कपड़े पहनने में कुछ तकलीफ होती है बेटा?
No? Okay. So 3 questions are very helpful to give an idea of pain or not. But I would say that if you have a suspicion of joint problem from the history, and there's still no pain which is verbalised or admitted to, still do a joint examination. Okay? So we may take you down here. So I'm going to ask you just to move for us, if that's okay. So if you want to come down here. So the first part of the examination, if you turn around and face the camera. Turn that way. Okay. So the first part of the examination is to have a look at general examination for stature. Is he in pain? Is he standing lopsided? Is he standing weight bearing on either side? Any obvious deformity, swelling, etc. Okay? So brief inspection from the front, from the side, and have a look at the back. We're not going to undress him completely today, but it's important to have certainly shoes and socks off, and ideally exposing just above the knee. So we may just pop up like that. Okay? You see some trauma on your leg. And then we'll get him to do some walking. So if you could walk to the camera for us, please, and then turn around and come back. So as we're watching him walking, we're looking for his whether he has a normal gait or not. So do it again for us. So we see, is he doing a normal heel strike and then a stance and then a toe off? Is he looking balanced? Is he limping? Is he obviously in pain? He may have some clues in his face from being in pain. That looks pretty good to me. And then can you try and walk on your heels for us like that? And walk to the camera again and turn round. And for a school-aged child this should be possible, but for a younger child this is difficult because of their development. That's lovely, come back. This is a very good way of assessing for the small joints of the foot as well as for the ankle. And again looking for symmetry, and any evidence of a limp is very important. Well done. Can you try now going up on tiptoes? That's right. Okay, and then walk across the room again and come back. So that's again very nicely done. You can see these walking quite symmetrically and come back. And again a good test for the small joints, the ankles, but also balance. And a child with hip problems may also have difficulty in doing that because they can't quite, if they have a hip contracture, they can't do that as well. So that's a very important start to the assessment. So that's gait. Okay.
Helen, can I stop you?
Okay.
When you walk on the tippy toes or on the heel, what does it tell you about the arch of the foot?
Okay. Yes, well, when we're looking at a child initially, we can see have they got a flat foot or not. And quite often young children have a flat foot because they're quite flexible and hypermobile. But if a child goes up on tiptoes, if the normal arch should form with a child with a normal flexible flat foot. The absence of an arch forming may give you a clue for either it could be a mid-foot problem, either inflammatory arthritis or sometimes an orthopedic problem like a coalition, tarsal coalition could be a problem, which could be symmetrical but more often it's asymmetrical. So a normal arch on tiptoe should be a normal feature. Okay?
Okay.
Thank you. So can we get you to think on this couch up here? I'm going to lift you up on here, so...
Okay.
Long way up. Okay. So I'm going to ask you to copy me with some maneuvers, alright? We'll look at
जो
your hands.
मैडम करेगी वैसे ही आप करना बेटा.
Okay. So I'll put the microphone down. And then, so, can you put your hands out forward like that? Okay. And then, do you want me to come? Okay. So hands out nice and straight, looking for any obvious deformity. If you can get his elbows out nice and straight. Do the fingers look straight? Are there any swellings there? Any rashes there? Okay, he looks quite comfortable. And then can you turn over for me? And that's full, we call that supination. Okay? So if a child can get to about here, there could be a problem with the wrist or the elbow or a combination. So full supination, well done. And there's no obvious rashes on his palms. His elbows are nice and straight. You might get a better view from the side. Okay? And then can you make a nice tight fist? Now normally the child can get the fingers tucked well into the palm. This is a very good assessment for the small joints of the fingers. Okay, so really like that. Well done. And for manual dexterity, just copy me doing that. That's brilliant. Well done. And then back over again. Okay. And if I just squeeze here, is that okay? Not causing any pain? Presume not. You might get some clues from looking at his face. Okay. I'm squeezing here the metacarpophalangeal joints, which are commonly affected with some forms of polyarticular JIA. And then this is the wrist manoeuvres, so like this. Okay, well done. And again, this is assessing the fingers, the wrist. You should be able to get easily up to a right angle either side. And a loss of movement might give you a clue for wrist involvement. This also assessed the elbows and a degree to the shoulders as well. So this is a very good manoeuvre to assess a number of different joints. And be careful to look for symmetry. Okay? Then can you try that? So, and then can we try and get you, just maybe to help. That's, so again, 90 degrees would be the norm. And children are usually much more flexible than adults, so that should be very easily done. Okay? And then can we get you to put your hands behind your head like that and push your elbows right back? So if they can come in front. So you do that, and then push right back. Okay. Yeah, well done. Okay, so that's assessing the elbows, also shoulders, and also sometimes a little bit of neck if he's trying really hard to move. And then hands above your head like that. This is a good way of checking for the elbows for hyperextension. Okay. So you might get a clue. Okay, is that all right? Okay, brilliant. So you might get a clue for hypermobility if the elbows hyperextend like that. Okay, that's great. And then you can relax. And if you look up at the ceiling for me, well done. So chin right up, chin right down like this. Just copy me, chin right down here. Well done. Okay. And put your ear on your shoulder. Okay, so ear like this. Okay. And the other way. Well done. Okay. And then open wide. 3 of your fingers. You get 3 of your fingers. Brilliant. And like this. Excellent. So we say 3 is normal. So 2 suggests limitation of movement. TMJs. But that looks 3. It's great. Well done. Okay. And then can we lie you down? So it might be easier if we, so head better this way, I think. So put your head back here. You lie down.
Let down. Keep in your pocket.
Easy like this actually. Is that okay on there? Is that okay? Okay, so I go this way. Okay. That's better actually. Is that okay for the camera? That's okay. Alright, so what we're doing here is having a good look. So look at one of the legs, part of the assessment. So we're going to expose. Alright, so we have a good look. What we're looking for here are any obvious skin changes, and we have a nasty area of trauma over his shin. Okay, and some scars from previous trauma, like old scars. We look for evidence of it, we look for alignment, which should be normal and straight. Muscle wasting, okay. There's no obvious leg length inequality. Check the soles of his feet for any evidence of trauma, which could be there if a child had a limp. Okay. And then feeling over his knees for warmth. And then assessing for an effusion. Okay. So what we're doing here is squeezing any fluid into the actual knee joint and assessing for a patellar tap. Okay. And then we now move the legs. So can you bend this leg? Can you bend up for me? Okay, well done. We try both sides to compare the range of movement. That's active movement. Okay, and then I'm just going to move you now. So put my hand over his knee, which will feel for crepitus, which may be there in some joint problems. So I'm going to bend your leg. So that's full knee flexion, and then we go to full hip flexion. Okay, and then we do internal rotation. Internal rotation is the first manoeuvre to go with hip pathology. You can do external as well if you want to, but internal is the bare minimum. Okay. And again, we ask about pain and we check for any visual clues of pain. And then we can check the other side as well. And then full hip flexion. And then internal rotation. Okay? And we don't do the foot and ankle here unless we've picked up something on the gait manoeuvres. And then we can sit him up, maybe look at his spine. So we're into the last part of it. So, should we get him back down there again, or should we stand? Can you?
You can stand.
You can stand. You stand up.
Better khade.
Not too tall. Okay, well done. So what we could do, if you turn around and face me. Okay, which doesn't fall off. Okay, we have a look at his back and make sure he hasn't got a scoliosis. Okay. Okay, and then can you bend forward and touch your toes? Okay. Okay, so you can see better than I can, but you check for any evidence of the curvature of his spine. Okay? Well done. And that's it. Well done, thank you. Get you down. So with a normal child, you should be able to go through those manoeuvres in about 2 minutes. Okay? About 2 minutes it takes, and you may pick up features of hypermobility very easily, which is quite common. Plastic bag. It's on the back seat. Okay. So you may pick up features of hypermobility. So with hypermobility you may get clues from doing this manoeuvre. You may get extremes of movement here. You may get extremes of hyperextension at the elbows here, or particularly on that manoeuvre. You may see something there. You may see flat feet on looking at the child standing with a normal arch on tiptoe. So hypermobility is commonly found, and P-gals will pick it up quite easily. Okay.
So this was a normal child.
Yeah.
And this was a normal child, and basically what we found was that you made one important remark. When you were talking about the hip, you said you do external rotation because that's the first movement to go.
Internal. Did I say external?
No, sorry.
No, internal
rotation,
okay.
Because that's the first movement to go.
Yeah.
So is that also why you do extension of the cervical spine, because that's the first movement to go there?
Yes.
Yeah.
Yes.
So now, Helen, I think let's all give a hand to this young volunteer. He's been fantastic. Come back. जाओ, आप अपने जगह.
Okay.
And now we'll watch Helen do the P-gals in a child who will show us some signs. Where you've seen normal, and now you'll see abnormals.
Hello.
Come, Fenwick. Jara.
We'll take his shoes off maybe, and we can't take his jeans off, can we? But we'll manage.
Chal, Fenwick. Abhi ja.
So we'll miss the questions for now. We'll
skip the questions.
Skip the questions.
Just
okay.
To recall, what are the three initial
Can we just
screening
undo your
questions?
card? Yeah.
What are the initial three screening questions? Any pain anywhere?
You okay?
Sorry?
Upstairs or downstairs?
Can you go up and down the stairs? And can you have difficulty dressing? These are your three screening questions.
Well done. And can we maybe just hitch up these a little bit? Maybe a little bit. Is that okay? I don't know how high they go, but you certainly see your foot and ankles. Maybe your knees too? Well done. Is that okay? Fantastic. Well done. So, if you just stand in the middle there, so have a look at him from the back. Shall I just comment as I go along what I see?
Sure.
Okay. But what I can see from the back, he looks quite straight, but I'm struck by the muscle wasting in his calves. If you turn around and face me, I think you can see he has quite striking muscle wasting on both sides, which is quite symmetrical. Okay. Okay, and he's looking from the side. Okay. All right. Okay, so can we ask you to walk for us? Can you just walk to the camera? Walk to the camera and come back. So he's not limping. Maybe go back again. He has a good heel strike, stance, toe off. He has a good arch. Okay. Can you try walking on your heels this time, like that? That's very good. Okay. Is that painful doing that? It's okay. Okay. You managed that very well. Okay, that's good. And you walk up on tiptoes now. So again, he's not limping. He's managing okay. Maybe not quite as easy as the previous little boy that we saw. Is that hurting doing that? Doesn't hurt. Okay. Okay. Remember, that's a good screen for the small joints of the feet. So we might note that maybe he wasn't quite able to do that. He managed it okay. It wasn't quite so as easy. Okay. Thank you. So can we get him up on here now?
Just one sign that I want you to observe in this child when you see him in profile.
Yeah,
you see a little retrognathia over here? Do you see a little retrognathia in profile which tells you a telltale sign that at one point in time his PM joints were in trouble?
Here. So can I lift you up? Can I maybe help you? Yeah, 1, 2, 3. Okay, well done. Okay, so if you sit like that, all right. So can you put your hands out for me? Okay. So what we can see here, shall I comment or shall I ask for comments from the floor?
I think ask the comment from
okay.
the floor.
So maybe those at the front can see more readily, but so he's doing this. So what can we see?
Would one of you come up front over here?
I think we want 2 or 3 volunteers as usual. Please come here.
Please come
on.
Front. Come.
Don't be shy.
Would you like to
I think it's just an observation. Come.
Just an
I think you have been talking. Come.
That's right. That's
come in.
nice.
Come in.
That's nice.
Come. Somebody from here.
And one from this side.
Yeah, come. And keep the mic in your hand and just go on talking whatever you see. Come.
So what do you see?
There is a limitation of extension of the of the phalangeal joints.
Which phalangeal joint?
Proximal phalangeal joint.
These ones? These ones? Okay. On both hands or just one hand?
More on the right and left. The middle finger is paired. This slight.
Okay. Just do looking for now. Just looking. What do you see? So we've got some evidence of maybe contractures.
Yeah.
In both hands, more so on the right, but over the proximal interphalangeal joints. Okay. And his posture at his wrists. What do you think about that? Is that okay?
Limitation
Are you
of
tired?
the extension.
Maybe I can help you I can hold your hands. Okay. He's maybe a bit tired.
There is limitation of the extension of the wrist joint.
Okay. Can you pull your hand up, Henrik? Can you pull? No, that's you can a bit. Yes. Okay. So he's a bit better. All right. Anything else about his elbows to comment on, or his general?
Right elbow is looking like more swollen than.
Yeah. So can you put straight as you can?
Left.
Yeah. So limitation of.
And extension of the elbow
joint. And muscle bulk. What do we? Any comments?
Gross wasting is there.
Yeah.
Of the muscles.
Well done. Okay. So, can you turn over for us? Okay. So if I maybe rest. You can rest on there. So any comments about his...
Supination
is not fully supinating the both arms.
Okay, so limited supination symmetrically, affecting both sides, but worse on that side maybe, worse limitation maybe. Okay, and what about... What else can we see? Yes, a limited extension of both elbows.
More limited on left side.
Okay, all right. And then can you make a fist?
Yeah.
So
he's able to flex the phalanges.
So he can do it, but there's some asymmetry of. Can you do that for us? Well done. And this one. So you take your thumb out the way. Try again. So you maybe can't quite get these two. These two aren't quite going down completely. So that may suggest some small joint involvement of the PIPs and or the DIPs, but maybe... Yeah, okay. On this side, take your thumb out the way. Can you try again? Try again this side. Maybe you can all see that he's trying really hard, but he can't quite get those fully into his palm. Is that hurting? Any pain doing that? It hurts a little bit? Okay, so we need to be careful. All right. Also, he has got some muscle wasting as well, isn't he?
Yes, on thumb side, the hypothenar and thenar muscles both are wasted.
Okay, well spotted, okay. And then back over that way. All right, so I'm just going to squeeze gently. Okay. All right. And there's no obvious swelling here, but he said it was quite uncomfortable doing that, but there's no obvious tenderness there. All right. And then, can you do...
Namaste.
And pull those up as best you can. So what do we see here?
He is again having limitation in doing that. He is not approxing both the palms, going down to the wrist. He is not even
try that.
Extending the both wrist.
Okay. Okay, so clearly some difficulty in doing that. Extension. And again involving both sides. And the fingers? Yeah, so contractures there. Okay. What about this?
So elbow flexion is good and wrist flexion is good. There's no limitation of elbow flexion or wrist flexion.
Okay. Whilst you're there, we may check for any evidence of skin psoriasis, which might be a clue for extra-articular feature, certain kinds of JIA. But there's no psoriasis there or other rashes. Okay, and there's no nodules either, which could be another extra-articular feature of some types of JIA. Okay, all right, and then do that for me. Comments?
Shoulder abduction is good in his case.
Yeah.
It's pretty good. Yeah.
Right. So what is important, I think she really needs to be applauded that she also looked at what was normal. While we were only focusing on abnormal, she realized that, well, in this situation, the shoulder is normal. Right?
Yeah. Okay. Because that's an important part of the pattern recognition as well. So elbows are restricted.
Again, elbow extension is restricted. He is not again extending both the fingers, fingers of the both hands.
Okay. And, well done. And do that for us. And push right back. That's pretty good. Yes, that's good for shoulders. And shoulders are not often affected with JIA. So that's actually something that we'd expect in JIA. Okay, relax. Down we go. Okay, and then
neck extend.
Head, look up at the ceiling. Very good. So
able to completely do that.
Yes, that's normal. It's very good.
So suppose you had a child with JI who can't extend his neck. What is the clinical implication for us? What is the setting in which we are worried about? This child has suddenly come to you for an acute appendicitis, something unrelated. Now what are you worried about? About intubation, right? So these can be very difficult patients to intubate, and that's the reason, that's the clinical implication of cervical spine involvement. Yeah? That's not so much the issue. The issue more is about your cervical spine extension, and the moment you try to hyperextend, it becomes very difficult.
Yeah. But that seemed very good. And then chin on chest.
And he is able to do completely.
Yeah, very good. Okay. Then put your ear on shoulder. And the other way. So
lateral flexion is good.
Very good. Okay. And then there's a comment being made, Dr. Raju, already about the jaw. Yeah. So what might we anticipate if when we do the jaw opening?
Temporomandibular joint would
so how many fingers should he get in?
3 fingers.
3 fingers. So do you want to try? Open wide. Bearing in mind his fingers are...
Problem with fingers.
So maybe try... Do your hand that... Can you do your hand that way? Okay, just try. It's remarkably okay, actually. It's okay. He may have a bit of an overbite as well, you see his teeth. So, because TMJ problems often create dental problems.
The deformity is more prominent and he is not. If the deformity is more prominent, he won't be able to do. If the patient won't be able to do, can we use assistant's finger or examiner finger? Means, can I use the fingers?
Yeah, okay.
Is it acceptable or not?
Generally speaking, our fingers are much bigger than a child's fingers, so I would say no, but you may have to improvise and say that 2 of yours are the equivalent to 3 of theirs.
But I will get the false impression of the test if he won't be able to do properly.
But I think he managed remarkably well, actually, even though his fingers aren't very straight. He managed to get certainly 3 side by side. So I think he was very good. But you may have to improvise. I take your point.
Thank you.
Okay. Where were we? That was good? Yes?
Yeah.
Yes, okay. So can we lie you down? Okay. So get him nice and straight. Okay. So we've exposed. It's important to expose above the knee because muscle wasting of the quadriceps muscle is what you might expect with knee problems. So it's important to expose above the knee as much as possible. Okay. So any comments from having a look at his leg alignment, his posture, his joints?
His knee joints appear prominent, that is maybe because of the wasting that he is having.
Okay.
And
okay.
They are in slight flexion, but
Yes.
because of that mattress or something.
Maybe, but I think you maybe can see certainly on this side. You could probably get your hand underneath, suggesting a contraction. Well done for spotting that. Okay. And
tell me, suppose you had. I'm just saying. Suppose you had seen this leg longer than this, right? In which joint is the disease? This joint or this joint?
in the shorter one.
In the shorter one. So how many say shorter one and how many say longer one and how many say both could be right? Yeah?
Both could.
So when? Yeah. What's
Early in the disease, because of increased inflammation, you may have longer length on the affected side. Eventually, because of the contracture, that joint may not grow further, and hence you might have the affected limb which is shorter than the normal.
So almost correct. If the disease has occurred before epiphysis has fused, hypervascularity leads to a large joint and therefore overgrowth on the inflamed side. On the other hand, if you have a disease which comes after epiphysis has fused, then the affected side will be the shorter side. Right?
yeah. What you may also see with a longer leg is that you may get a degree of valgus forming, because it's a way of compensating, if you like, for the increased length on that affected side. So it's important to comment on the alignment and any obvious leg length discrepancy.
So not as a part of P-GALS, Helen, if I may interject, a very quick sign to document inequality of the limbs is called the Galeazzi sign. The Galeazzi sign. You know, what do you do in the Galeazzi? You seem to know it. Come, show me. What will you do in the Galeazzi sign? Come. Take your...
We flex both the legs at the knees and look for the level of both the knees joints.
Absolutely.
Put these together at the back.
You align these together,
So they're
flex
together.
both the knees, and then look from here to see whether both the knees are at the same level or not. Excellent. Well done. I think she deserves a hand of applause. Yeah?
Sir, can you tell us about the squaring importance of squaring? Squaring the pelvis when we check the limb length. Is that important?
Yeah, because if you don't centralize it, you're obviously going to get a limb length discrepancy the moment you try to measure with the tape.
Thank you.
So you do that by checking that his iliac crests are the same. Okay, because just make sure he's correctly positioned on the bed. Okay, so we've had a good look. All right, so there's a muscle wasting, but alignment is good. Okay, no obvious leg length discrepancy. We would agree. Okay, so then we go into the feeling for temperature, which feels fine to me. Okay, and then
there is one subtle sign over here, which you will appreciate when you're standing. Yeah, which you will appreciate when you're standing there, and I'd like any volunteer to come and see, and earn himself a chocolate if he says what he finds. Come, anybody?
So there is a volunteer there. Why don't you earn a chocolate?
Come, you've been silent for a while. Come, tell me. What are you seeing here?
The patella of the right side is inwards, it's facing...
Absolutely bang on. Absolutely bang on. Perfect. The patella on the right side seems slightly medially turned as compared to the one here, which is straight looking at the ceiling. Yeah? Okay.
And that might suggest what? A problem with his Do you want to?
There's medial dislocation of the patella, perhaps.
Yeah.
Yeah.
Or sometimes increased rotation at the hips, maybe. Maybe a problem more proximally.
Yeah, it could very well represent the fact that your medial vastus has undergone a little bit of a contracture, which is pulling the patella this way, right? But you very clearly observed that this patella is not where it should be, right?
Okay. So, and then there's no evidence of any increased temperature. What we're doing here is, if you have an effusion of the knee, it may expand into the distal thigh. So it's important that we just milk fluid down. Comments about that?
Limitation in the flexion of the knee.
Flexion of
Knee.
the knee. Okay. And we try the other way. You try again. Okay. So same again. So.
Dr. Helen, I have a question here. Why are you making him do this voluntarily first and then moving it? What is the purpose behind that?
Okay, so that's initially is active movements, and then we do passively afterwards. The active movements give us a good idea of what he can do with degrees of comfort. So I'll be much more careful about when I do things passively.
Thank you.
But in a very young child, you may have to miss out the active movement and go straight to passive. Okay, but it's important to Okay, so
active movements are less dangerous when you're examining the child. Passive movement in a very osteoporotic child who's got long-standing disease has been very, very, very occasionally, but known to even create a fracture. So you've got to be careful.
I think the bottom line is you realize what the patient's limitations are and then work according to that.
Yeah. So we know you can get to about 90 degrees of flexion. We need to be careful. Okay, so I'm going to bend your leg now. So I'm going to 90. Okay, that is it. This is knee to 90. And I'll try then moving his hip. Is that okay? I think he's saying yes. But that's probably limited. Okay. So that's his hip flexion. And then we'll try this one. So knee to 90. And I can't, he's actually resisting me. If I go any further, I can feel him resisting. So I've got to be careful. Okay? So his hip movements are also limited. Alright? And whilst I'm doing that, P-Gals is very simple, but I might see evidence of a hip contracture. So if I do that, and his right leg pops up, you may have evidence of a hip contracture. Okay, that's Thomas test. Okay? And then whilst we're up here, we can look for internal rotation. So you can do it all as one big maneuver, but so flexion, and then internal. Okay?
So now we are going to do something which is different. I want one volunteer to come and say that he will do the P-Gals on our third patient before we wind up.
One thing. Do we test the axial this by asking the child to turn and sit this to see the vertebral and this?
So you just ask him to bend forward.
Yeah. Just bend.
Yeah.
Bend forward and examine his spine. This is just a screening examination.
Yeah, exactly.
Right? So this is just a screening. So what is P-REMS?
Right, so P-REMS is the Pediatric Regional Examination of the Musculoskeletal System.
Yeah.
So P-Gals is very simple, top-to-toe examination, is a joint abnormal or normal. If you find a problem in a certain area, you then go to a more detailed examination, which is, there's a P-REMS of the hip, P-REMS of the knee, the foot and ankle, the hand. So it's based on a look, feel, move, function, measure approach.
So the articular, the synovial thickening and all you see in those?
So the P-Gals is a screening test.
Yeah.
The P-REMS will be then, now you've identified that, okay, it is the wrist which is in trouble. Now you're going to specifically look at the wrist and say this is where we are.
Yeah.
Just a doubt, because P-Gals is a screening test. So in already a child who has a JI, you would still do a P-Gals to see new involvement or?
Yeah, because when he came to me the next time, right, now suppose he's a fresh case, right, when he comes to me, in the first time he had his joints inflamed, So I did a P-GALS and quickly found that it's his wrist which is in trouble, it's his left knee which is in trouble, and it's his maybe small joints of his right finger which are in trouble. He comes 3 months later, he's been on steroid and methotrexate, right? And then I do the P-GALS when he walks in and I find that he's absolutely okay. Now, this case is slightly different because this child has had a very long-standing history and today he's already having, a residual deformity. In fact, he had residual deformity even before we saw him. I saw him when he was about 5 years of age and been following up since then. But even by the time when he came, he was not mobile. He was carried in on his father's lap. That's when he came in. So is somebody going to volunteer?
So before that, I have some questions.
Yeah.
Question came from the web, whether this is useful for congenital conditions. So I want to make a comment here, and you tell me whether my thought process is right or not. You said in a busy practice this would be a good screen. And I think primarily it would be useful to discover areas of involvement other than what is obviously presented by the patient when he comes to you, so that you can decide what to do further.
Yep.
The detailed examination, the PREMS which you are talking about, is probably the domain of a pediatric rheumatologist.
Yep.
As a generalist, it is my concern to identify the extent of disease and then decide whether he needs to go to a rheumatologist. Yep. And for that, P-GALS is very important. Is that correct?
So if I think that's a very, very sensible way to look at it.
So if I have a developmental dysplasia of the hip, I am not expecting any other abnormality, so I know what his problem is. So it should not be used unintelligently for anyone who's got a deformity. If it's a congenital thing which is known, which is not known to have any other affection, maybe you wouldn't do it also. Is that correct?
No, but how will you determine that he has developmental dysplasia of the hip the very first time you see him?
Sir, usually in our papers it is written, a known case of DDH. So I'm just saying that.
Yeah. But how do you know?
Fair enough, I got your point.
When he came to you the very first time, he was an unknown case of DDH.
Yes, absolutely. No, the point taken. So then even then you would do that.
When you saw him limping in, and lurching more on one side, you said, hey, why is this? He's a very happy looking kid, but he's lurching on one side and weight bearing the other way. So he has a Trendelenburg type gait. So let me examine him carefully. That's when, and at that stage you still don't know whether his elbow is involved or what is involved. And then you do that and finally come to see that it's only his hip that's bothering him. Then you say, okay, this is a 4-year-old guy who's otherwise absolutely well, no extra-articular features, with an isolated hip. So this could be DDH or it could be Perthes.
Absolutely.
Yeah. And then move forward.
Yes, I would use P-GALS as a way to reassure you that there's no other problems of joint involvement elsewhere.
The only complaint I have, sir, is that if we had done this clinic 2 months back, maybe a lot more candidates would have passed, because for the DNB exam this time there was an OSCE on P-GALS, which was a 10-mark question, which is very vital, I feel. So I think even the board is recognizing the importance of the P-GALS.
So I think let's just reinforce the message in that we have an older boy who's about 18 years, and would anybody like to demonstrate P-GALS in literally 2 minutes in him? Will you do it? Come. Amol, Babu, ithe ye zara.
Fenwick's finished.
Yeah.
Want to put you back together? Put your trousers down again. Let's see. There you go. Well done. Well done. Okay. Well done.
Hello. Good evening. नाव काय आहे? ओके. मी पीडियाट्रिक स्टुडंट आहे. फक्त 2 मिनिटात एक्झामिनेशन करून घेतो. ओके. टी वगैरे झालं का? I will be using Hindi language because it is webcast. It will be helpful for others also. I will try my best. I try to finish as soon as possible. I have to ask 3 questions. One is, आपको कहीं पे दर्द दे रहा है क्या? नहीं. और आप आराम से स्टेप चढ़ सकते हो क्या? और उतर भी सकते हो? और अपने कपड़े ड्रेस अनड्रेस कर सकते हो क्या? ओके. These are the three basic questions we have to ask before proceeding. Then next, I will tell him to walk first straight line. First, I will examine his back once he enters into the examination room or chamber, from the back and from the front for any findings. For me, he seems to be looking quite okay from the back as well as from the front. So
you have missed something in the front. You have missed something in the front. Okay, so he will need help. Will somebody else come and volunteer just for 1 minute? Come.
Retrography plus his foot on the right foot, it is not okay. Means it's like flexion of the forefoot, I can say, dorsum of the foot. Yeah. And
what do you say about the toes?
Toes, the 3 and 4, they are short as compared to second toe.
And are they not bent?
Yes, they are bent, sir.
Yeah, okay.
Then next will be, I will give instruction to walk straight line. So, वहाँ तक जाके आओ straight line. So I can tell that he is slightly limping. और एक बार. Definitely it is not a normal gait. He has slightly limping, maybe because of his the quite obvious is like one side his spine is a little bit bending. I can say it could be lordosis on the left side. So that's why his gait is not up to normal. Next is I will tell him to walk on a tip of the heel. ऐसे चलोगे? नहीं, सुनो एक बार देख लो, ऐसे चलना है.
Tricky.
पूरा उठा के चल सकते हो. Again, there is a difficulty while walking. His how we normally walk, it's definitely difficult.
What is a painful gait called?
Antalgic gait. Then next instruction will be, I will tell him to walk on the tiptoes from front. ऐसे आगे से चलो. In this, he is quite comfortable as compared to before.
Can I make a comment about when he was doing his heel walking?
Yes, ma'am.
Difficulty in doing that. Probably also because he had a deep lordosis.
Yes, ma'am.
So he may well have a hip contracture, which is affecting him doing the heel walk.
Yes, ma'am.
Yeah.
Next, I will make him to sit on this.
You want to come up here, or want to come this side, or?
मैं जैसे बोलूँगा आप करोगे.
Brilliant. Okay, well done. Shall I hold it?
We'll hold it. No problem.
First thing I will tell him to make it straight. Straight करो. Okay. इतना ही होता है. On inspection, ये straight नहीं कर सकते हो. So I can see slightly his interphalangeal joint in a fixed flexion deformity as compared to left side. It is right more. and obviously there is a difficulty to completely extend his elbow on the right side as compared to left side.
No, wait. There is something else. Please. Now,
Wasting.
Now I'm going to have the prerogative of calling somebody who hasn't said anything at all. Okay. So, madam, you come here. Come. There is something else that we want you to point out.
Fine tremors of the fingers.
No, that's okay. That's okay. If I would be in his place, perhaps even I'd have the fine tremor just now. So that's not what bothering me.
Thumb on the
yeah.
The right ring finger, there is a contracture.
That's a contracture. Okay. What else?
Even the thumb on the left side, at the distal interphalangeal joint.
What else?
Even right ring finger is distal interphalangeal joint is like slightly flexed, sir.
Okay. And what are you seeing on the proximal interphalangeal joint?
The proximal interphalangeal joint is a contracture at the middle finger and...
he has fine nodular type of deformities, like prominence of...
What are you seeing in this thumb?
The thumb is hyperextended, abducted, extended.
Exactly. Okay. So remember...
Sir, please take the mic.
I'm sorry. I'm really sorry, Anand. Remember that hyperextension can be one of the late complications of a scarred joint. Okay? And you can see that hyperextension even over here. Can you see the hyperextension over here? Right? So these are all spots where there is hyperextension that you should have noticed. Okay. Right? Okay, madam. Thank you.
So we would call those ones swan neck deformity? You still call? We're going to ask that question, were you?
Yeah.
Sorry if I spoiled your question.
No.
Sorry.
Go ahead.
So the hyperextension, I used to be able to do it, that shape is the swan neck deformity, if I can do it. And that one is called, so flexion here and hyperextension at the DIP, that's called Boutonnières, yes. Okay.
So when there's flexion here and extension here, it's boutonnières. The other way is swan neck.
Yeah, that one.
Right?
Yeah.
Yeah. Sorry.
नेक्स्ट ऐसे करो, ऐसे कंप्लीट ऐसे मुट्ठी बना दो, ऐसे हो सकता है. ओके. नेक्स्ट ऐसे करो, ऐसे पूरे रिवर्स. ठीक, गुड. उसके बाद ऐसे करो. मे बी माई ऑर्डर इज अदर वे. ऐसे करो. उसके बाद नमस्ते करो, अच्छा सा करो ऐसे, और ऐसे अच्छा सा उठाओ. इतना ही होता है. डेफिनेटली देयर इज a dorsiflexion of the wrist of the both hands is restricted. It is not up to 90 degree. ऐसे करो, अच्छा सा ऐसे करो. Compared to previous one, it's I mean still restriction is present at compared. Wrist flexion is preserved as compared to dorsiflexion. Then ऊपर देख सकते हो, नीचे, फिर ऐसे ऊपर करो, पूरा ऊपर.
Is this symmetrical? Is this symmetrical?
अच्छा सा ऊपर करो, ऐसे हाथ फैलाओ, ऐसे दोनों हाथ फैलाओ.
He is having difficult to abduct the right arm.
And his fingers ऐसे नहीं हो सकते. हाँ.
Okay. And then
ऐसे ऐसे इधर टच करो. ऐसे तीन ऐसे पहले ऐसे पकड़ो. He has definitely difficulty to insert.
Putting 3 fingers, he has difficulty. And very subtly, if you looked, even his neck extension was not as limited. Easy as the very first child who did it.
Okay.
Yeah?
So, yeah.
So now what we'll do is, we'll take this as done because this is becoming a little monotonous now. And we perhaps have about 20 minutes left. So why don't we take free questions from anybody in the audience regarding examination?
Yeah.
ठीक है. Thank you.
Have the pain
Absolutely. Okay. So I think we have a chalk and a board over here. And Helen, Dr. Prabhu asks a question. How do you record the P-GAL's features? So, would you just draw that matrix and show it to her?
Can I draw? No, here, they're here. This one. This one?
I hope that it won't write.
Maybe the chalk better? Yeah. Okay, thank you. Thank you. That's good. Okay. Okay. And here we have appearance, A for appearance. And we have M for movement. Okay. And then we have A for arms. Oh, sorry. Gait. Okay. Arms. Okay. So you could actually, make it even shorter by just GALS, appearance and movement. And then if something's correct, there's no problem, you can put a tick or a cross. Okay, so like in the last young man, he had a problem with his gait, so we'd say his gait appearance wasn't quite right, and we could say his movement wasn't quite right, and we can make a description, a free text comment underneath. So for the arms, we could say, for example, if you had a child who had a limited wrist movement, we could say that the appearance wasn't right, and or it may have a swelling, or you may have restriction of, say, dorsiflexion of wrist. If the lower limbs are fine, you could say fine on appearance, fine on movement, spine appearance is fine, and on movement there was no problem. So cross and tick, and you can annotate underneath the free text. Okay? You could write underneath, so for example, another example, a very good example might be, say, a child with a single swollen right knee with a contracture. Okay? You might put down that the appearance is not right. You could put down, and then you could say that the movement was not right. So you could put down, say, right knee effusion. You could put down contracture. So keep it very brief like that. Okay.
Her question was, do you make a separate grid for the right side and the left side, or you record the right and left in this grid itself?
I think you can do it either way, whichever works for you. I tend to do it like this, just annotate underneath. You could do it different ways.
Again, the purpose of this is to identify which part is abnormal and requires a greater...
Yes.
So if the arms are not okay and you've given a cross, which means that you have to do a REMS for that.
Yes.
And then go into further details. This is not the end of the assessment. It is the start of focusing.
Yeah.
Absolutely.
And if the child already answers your question, the child has pain, then how do you interpret? Say the child has pain
In
or
your
is
screening
having
questions,
difficulty.
Right.
there was a yes to any of the three.
Okay.
Then how does that change your approach? Is that right?
Yeah. If a child answers pain, you might then follow it up and say, well, where do you have the pain? And it might make you much more of a heightened awareness to examine that area in more detail and be more careful in how you approach the child in case you hurt them. But even in the absence of pain, I'd still be having a look, because you might pick up problems that weren't obvious from the child feeling pain or from the history.
And I'll give you a very typical example of a child I just saw this morning. This kid has come with pain in the left knee. So the dominant feature with this child was the limp because of pain in the left knee. And that's all the focus that the mother had. Now, here is a setting where you would think, after your P-GALs or whatever, that this is a monoarticular knee and your list of differentials will be A, B, C, D, E. You examine this kid very carefully and her third right toe is swollen. Right? The entire focus changes with that one single finding, because now you have a dactylitis in addition to a left knee. You could be dealing with a reactive arthritis, you could be dealing with a psoriatic arthritis, you could be dealing with something entirely different from where this happened. So therefore, where is your pain is a screening question, because it basically, the patient answers where is the dominant pain. There may be other sites which you may discover on examination.
Yeah. And don't forget referred pain. So a child with a painful knee, if you examine the knee and it's normal, you must also think about hip pathology. So.
You want to ask?
This is not related to examination, just as a practical point, that we see cases of chikungunya and transient synovitis. Could you just enlighten as far as the diagnosis reached in them with joint involvement?
So I think transient synovitis of the hip is a reasonably straightforward diagnosis. Okay. This is a usually 4 to 8-year-old boy. Could be a girl also, but there's a little male predilection. This child has had a recent viral respiratory infection and went to sleep reasonably happy and gets up in the morning unable to weight bear. He comes to the hospital. He doesn't look so sick. He's in pain, but he doesn't look so sick. You examine him, and if you do a P-GALs in him, you will find his internal rotation of the hip is limited. He's mildly febrile. You do a white cell count. It's not 20, 30,000. His ESR is 30, 35, 40, seldom more than that. His hemoglobin is good. And you're pretty sure that this is a transient synovitis of the hip. You do a sonography of that hip. You identify fluid in that hip joint. And with this sort of scenario, you don't even wish to do a tap to suspect septic arthritis, unless, of course, the count was very high, the ESR was very high, the child was more toxic, the fever was very high, there was a septic focus visible somewhere else. Then your differential diagnosis would be septic arthritis. Okay. As far as chikungunya is concerned, I have to make one small confession, and I'm making that even at the cost of looking stupid and ignorant. I haven't diagnosed the case so far. Now, perhaps you call it urban snobbery, or perhaps you call it ignorance on my part that I don't know, but most often the rural patient who has been diagnosed as chikungunya and has been referred to us here I'm able to give him an alternative label. And a credible alternative label. So, I'm sure there is chikungunya around. It is a known recognized disease entity. Multiple polyarticular joint pains, viral prodrome. But I don't feel qualified to talk enough because I don't think I've seen enough cases here.
Sir, some questions from the web.
Yeah.
So the first question was, for internal rotation at the hip, how do you differentiate between a contracture and inflammation? My common sense answer would be the pain associated. But is that correct, or would you like to?
That's absolutely correct. Pain at the end of range of movement suggests an inflamed joint.
Heel walking may be affected because of muscular diseases also, or a neurological disease also. So again,
and this is the setting where I'm going to tell the parents that I don't have an answer yet. We are going to start an NSAID on your child, right? And perhaps if the child is not so sick, I may not even start an NSAID. I may just say, let's keep paracetamol going. Don't start any wonder drugs because you wonder what it will do next. And then just wait and watch and see how the story moves.
So from this I also realize that you focus a lot on the platelets. That gives you a lot of clues?
Absolutely, because thrombocytosis will tell me about a disease like systemic onset GI.
But why do the platelets go up?
It's an acute phase reactant basically. So that's the reason the platelets would go up.
Raju, you told about the pattern recognition. This child you saw 3 months or 4 months down the line. So all your
3 years down the line.
No, suppose you saw him.
Yeah.
So all your reactive arthritis and all are gone. Now, based only on these 4 facts, that this particular child is a male child. His disease has started at 2 years of age. There are multiple joints involved. And the pattern of joint involved. What is your bet of the diagnosis at that?
By this time, I am
going by the age, by the sex, by the multiple joints involved, pattern of involvement, and absence of systemic manifestations.
Absence of systemic. No, there is presence of systemic manifestation.
No, you have seen
he had fever when he started.
Yeah, you have seen him after 3 months and he now only has joint manifestations.
He only has joint manifestations. I will still like to probe a little further. Do you know why? There is one set of diseases which can do similar if he has no fever when he comes to me, and that is immunodeficiency syndromes. Okay? You can have a patient who comes with multiple swollen joints, right, and turn out to have Bruton's hypogammaglobulinemia. Right? So, but those children usually have their diagnosis written on their ears. They come with cotton buds in their ears because they have leaky ears on both sides. Okay? Or there's a history of multiple multifocal infections. Right? But having ruled that out by and large, I am left with only JI. Remember that the longer the duration of fever, the less the likelihood of infection. The even longer the duration of fever, the more likely you're dealing with a rheumatological cause. Malignancies also will get picked up somewhere between weeks to months, but not months to years. The moment you have a disease that's going on months to years, you can be reasonably sure that you're looking at a rheumatologic cause.
Sometimes we see a growing pain type of a pain, but unilateral, no physical findings. Then what do you do in that? I mean, the features are it's at the end of the day or more at night. Age group is matching, but it's unilateral or predominantly unilateral.
So I would look at this as a red herring, and I would not straight away jump to label this as a growing pain. I would look as to whether this child has any foot alignment defects, whether this child has the possibility of a unilateral flat foot, a pes cavus. I would like to look whether there is the possibility of a tarsal coalition on one side. Is there a valgus or varus deformity on one side? Is there something like a perthes on one side? So there are endless possibilities, and I would not certainly jump till I have made a very, very clear story. And just to illustrate an example, I've seen a couple of kids like this, and with no signs at all. But you make him lie down, and the first part of P-GALS you're looking, and you find that his quadriceps on one side is a little wasted as compared to the other. And then you tell yourself, why is this happening? What's the reason? And you examine his joints, everything is great. And this is a good setting where you ask for a radionuclide scan. Okay? And we picked up two diagnoses this way. One, a child with a chronic osteomyelitis who had on the shaft of the tibia an area which lit up straight away, and another child with an osteoid osteoma. So, unilateral pain, keep your antennae up.
Typical case of growing pains, how many of them have hypermobility, and what is hypermobility a confirmatory test? What is the cross percentage?
Thesis topic of one of my postgraduate students, hypermobility and growing pains. We found a very strong correlation in that when we did a 2x2 test, we found that large number of children with growing pains were hypermobile and a large number of children who were hypermobile had growing pains, thereby showing that there is definitely some association. But will be oversimplification to say that hypermobility is the only cause. When you do find hypermobility in a setup with growing pains, it becomes a peg on which you can hang your hat to explain to the patient and the parent that perhaps this could be the reason for the child's trouble, and give you a method of counseling them that they should look at doing exercises which involve non-weight bearing and yet strengthening their muscles, doing something like swimming and cycling which would help the child better.
So I think we are now, we've finished our time. So I'd like to say a few things, sir. Sir, you as rheumatologists, and ma'am, you too as rheumatologists, see these kind of patients day in and day out. For you, it's very easy to remember all these patterns. For us, today we are very charged up. We have heard you talk. And tomorrow, maybe for a week or 10 days, we may recognize a few patterns. But after some time, it's going to fade away again. And the next rheumatology type of patient we get a little anxious. In such a setting, having a weapon or a armor thing like P-GALS is very useful because it can sort of systemize my thinking and help me localize where the problem is. And for that, we are really grateful to both of you for having done this for us. Thank you so much for a delightful...
Anand, let me end with one important statement. You know why Helen is here? Helen has authored a website that's called pmm.org. Now, this website is a free access website. And this website, on the chance of a meeting in Europe sometime last year, we got chatting with each other, and I said to her that you've got all the material there, why don't we take this website and Indianize it? Which meant putting pictures of Indian children, showing rashes on Indian skin, showing certain pathologies which they don't see there like tuberculosis and rheumatic fever, and showing certain maneuvers like sitting cross-legged, which they don't really do over there. And the Indianization of the website is now complete. She was here to add finishing touches and to sign an agreement with the IAP with the University of Newcastle. This agreement has been signed just day before yesterday, but meantime we had completed our work. What will happen is that this website will teach you basics of pediatric rheumatology, and the Indianized version will go live on, we hope or expect, the 15th of August. Now when it goes live, everybody can watch the website. Everybody can watch the website, but there's an icing on the cake. The icing on the cake is that anybody who desires to be certified can go to the IAP website and appear for an online test, which will be an MC test, open to IAP members only for certain logistic reasons. It will be an MCQ best single answer test of 30 questions and 30 with no negative marking, 60% to pass, and you will get a certificate with the logos of IAP and the University of Newcastle. And the certification will be available for a very small fee, while the website is free for everybody to access. We hope that the certification will go online on Teachers' Day, while the website will go online on Independence Day. Is that right, Helen?
That's what we hope. That's right. That's the target.
Yeah.
Thank you so much, sir. A couple of announcements before we wind up today's clinic. The next broadcast will be from Chennai, Kanchi Kamakoti Child's Trust Hospital. Dr. Balasubramaniam will be in charge of that, starting at 2:30 p.m. on the 22nd of July. See you there.
Raju, you should say ki gal hai, pi gal hai.
One sec, before you all go, some announcement.